ahead and get started. This afternoon, our guest speaker today is Dr. Vea from Department of Interventional Radiology. He originally did his training in the Philippines, but then came to LSU New Orleans for his interventional training. Went back to the Philippines for a couple of years and then returned to actually LSU New Orleans. Katrina happened and we got him. And he's been here ever since, leading our interventional team. Here to talk to us about uterine artery embolization.
Thank you for the invitation. So, what I hope you don't mind if I sit on the stool.
No,
Okay. The approach will be evidence-based medicine. I will center on a particular case that I did about 2 months ago. So, this is the introduction. If you go with evidence-based medicine, you go for the highest evidence, meta-analysis, systematic review, RCT. So most of the evidence that I will be pointing here, I will make citations, will be on meta-analysis and systematic review, and a few review of some of the representative randomized clinical trial. This is the search cascade I use, and I would recommend this for if the research questions about intervention. You start with the Cochrane library. Why? Because it's already appraised. You don't have to appraise the data. And then if you find a systematic review by Cochrane, then you don't have to go down the line. And fortunately, I found one, so I stopped in there. And then the other one that I use is TRIP, Translating Research into Practice, the database. And by using this one, I was able to find 830 results. But these are already arranged by quality. And I choose only two from these two systematic reviews. And for the clinical practice guidelines, you are familiar with the National Guideline Clearinghouse in the US. And the counterpart in the UK is called NICE, National Institute for Healthcare and Excellence. So I use this as my search engine for clinical practice guidelines. So I think you're familiar with this, a recent case in the month of August. 46 years old, so all of the symptoms of fibroid, menorrhagia, pain, and then poor surgical candidate, and then unresponsive to pharmacologic treatment, and then symptoms of pressure and dysuria, and then initially refusing fibroid embolization and eventually consented to fibroid embolization. So what are the indications for this procedure? Heavy menstrual bleeding, pelvic pressure, similar to the indications for hysterectomy. Contraindications, of course, no need to say, pregnancy, suspected cancer, but although occasionally embolization could be used to devascularize the tumor before surgical intervention. And then relative contraindications include coagulopathy, requirement for continuous anticoagulation, wherein it's not safe to discontinue anticoagulation, renal insufficiency because you use a lot of contrast medium, prior allergic reaction, you can give some pre-meds, and of course, desire to have pregnancy in the next 2 years. Or probably the desire to have pregnancy not necessarily in the next 2 years. So how is pregnancy affected by UFEs? I want to start with this one because this will be the problem being asked by the patient if he wants to retain the uterus and at the same time he wants to go on with pregnancy. So theoretically, the flow to the uterus is temporarily decreased. How does this affect the ability to become pregnant? How this affect the ability to carry on pregnancy to term? In most patients, there will be reopening of the occluded blood vessels, and they are rarely permanent. And then the theoretical problem of weakening of the uterine wall, especially with large fibroid. And then difficult to predict if there will be problem during delivery. And then we have to use the sonogram to assess implantation problem or to assess overall integrity of the wall of the uterus. I don't want to bore you with these figures, but we need this. Look at a series of 5. I just focus your attention to this. When you look at complications of pregnancy after a UFE, you would see that spontaneous abortion is 30%. Then premature delivery is 21%, and high prevalence of C-section, 74%. and then small for gestational age, about 7%. Fortunately, there's been no report of postpartum hemorrhage after a UFE. When you look at the most recent data in 2007, you would see in here that, again, the same problem: spontaneous abortion, abnormal placentation, very low birth weight, and then the preterm delivery. And what is the bottom line? According to this publication, desired future pregnancy remains to be a relative contraindication to the performance of this procedure. And then successful pregnancy has been carried out, but the problem is there should be close monitoring similar to a high-risk pregnancy. When you look at the systematic review, this is the highest of the evidence. It is a systematic review of 6 RCT that is, I think, closely scrutinized as far as quality is concerned by the Cochrane collaboration. When you see in here the forest plot, it favors surgery. Take note that the diamond does not cross the line of no effect. Just a reminder, this is the anatomy of what you call a forest plot. The line in here is the line of no effect. The diamonds, the combined results of the meta-analysis. If the diamond would cross the vertical line, then the confidence interval crosses that, and it's not significant. But in this particular case, we can see that the diamond is not crossing the line of no effect, so there is a significant result favoring surgery over that of fibroid embolization. Then you look at raw data. As far as pregnancy outcome is concerned, 50% only in the fibroid embolization group and 78% in the surgical group. Much more so when you look at outcome, live birth. Again, you would see that it favors surgery. Then we look at the raw data, 23% only in the embolization group and 48% in the surgical group. If you go back, 50 initially in the embolization group, and now live term is only 23%, as opposed to surgical intervention, 78%, and then ability to carry to a live term birth is 48%. So let's go back to the case. Uterus is 13.5 by 10.4, about 16.3. So it's less than a 20-week gestational age size of the uterus. It's 13.5. This is the transverse cut. You will see that the fibroid at the lower uterine segment is large. And this is the MRI. The fibroid size, there are 2 dominant ones. In the lower uterine segment, you will see 9.3 cm. And in the fundal area, you would see 6 cm. And then this is the coronal cut. You would see that a high signal within the large one. These are necrotic tissue, non-viable tissue. And then the one in the fundus is entirely viable. So it's not showing high intensity signals. And then with regards to perfusion, after contrast was given, you would see that the uterus is vascular. But the problem is there are a lot of non-viable tissue in this large lower segment fibroid. But the remaining part of this fibroid is still viable. So how about the influence of fibroid size, you may ask? There is no definite limit to the size of the uterus that will benefit from UFE, but there are conflicting studies on this. One study would claim that for every 100 cc of uterine volume, there is a decrease in the outcome. And then some say that a uterus greater than 20-week gestational age, shrinkage may be unsatisfactory, and in one series, 4.5% ultimately underwent hysterectomy to resolve the symptoms. Other studies say that there is no safety concern, especially in the series 71, dominant fibroid that is more than 10 cm. But look at the other study. They said that if the fibroid or the uterus is more than 24 weeks age of gestation in size, and the fibroids are larger than 10 cm, then you could be prone to complications like abdominal pain, infection, sepsis, ischemic injury to the uterus, and the need for emergency hysterectomy. A particular subset is subserosal fibroid. The reason being is that if the stalk is narrow, they could detach and then roll over into the peritoneal cavity. They could infect and they could cause sepsis. For that reason, surgical intervention is needed. As a guideline, if we see that the stalk is attaching to the uterus by less than 50%, then it is more suitable for myomectomy. Unless, of course, there are a lot of high-risk medical conditions. Another subset is pedunculated submucosal fibroid. The concern of this is the one is you have to devascularize them, and they become detached. And as they become detached, they become incarcerated in the cervix. But fortunately, most of them could be expelled spontaneously without the need for intervention. And the clinical guideline is that if they don't pass out within 2 to 3 days, then you have to extract them by some manipulation. This is a Barrett case, so you would see in here a large fibroid spontaneously coming out, and now you would see the uterus almost normal in appearance. How about appropriateness criteria? So based on this appropriateness criteria, the case in point is appropriate, meaning the size is within the limitation, size of the fibroid is within limitation, so it's an appropriate indication for fibroid embolization, especially in the setting of high-risk comorbid medical conditions. How about adenomyosis? This is also a minor problem. As you would see in here, it could be concurrent with fibroid in about 10 to 20% of cases. And you know that the only definitive treatment is hysterectomy. But preliminary data show that using embo alone, there could be some diminution of the symptoms. But again, the problem is recurrence after 1 year is 50%. How about what is the current guideline on this? This is the nice one, the UK. This is current one, 2013. I think they are recommending also the use of embolization for treating adenomyosis. I don't have time to show you the evidence, but following this article, there's a lot of evidence that they have cited in this particular clinical practice guidelines. How about the American College of Radiology appropriateness criteria? You would see in here that the score given for embolization is 7, similar to the score that's given for hysterectomy. But again, if there are no reasons for you no reasons to avoid hysterectomy, like the patient is refusing it, or there are no comorbidities that would make the surgery high risk, then of course hysterectomy is favored over that of uterine fibroid embolization because of the high recurrence after 1 year. I was supposed to be showing the CNM, but unfortunately it's not compatible with the computer. So this is the MRI. With MRI, you can have a vascular study. And what you're looking at the vascular study is the vascularity of the fibroid. So you would see in here that the fibroid is highly vascular. Why? You have to know that the fibroid would have a vascular substrate for your embolization to work. Meaning calcified fibroid or fibroid that has undergone degeneration, they're not suitable for fibroid embolization because the principle is devascularize them. And why do you devascularize already a dead or a calcified fibroid? So schematically, this is how we do it. So puncture in the groin, we put it in the aorta, and then selectively go into the internal iliac artery, and then selectively go into the uterine artery, and then inject contrast and find the fibroid blood supply, and then put your catheter selectively. And once your catheter is selectively into the fibroid supply, then you shower them with particles. Actual case, so you would see a very large fibroid. You will see that the catheter is already selective into the distal part of the horizontal segment of the uterine artery on the left side. And that's the fibroid supply going vertically into a large fibroid. And then this is the finished product. You would see that the fibroid has been devascularized entirely. And we have preserved the vertical as well as the horizontal segment of the uterine artery as well as the cervicovaginal branches. So as a rule, we have to preserve the cervicovaginal branches for the same reason that this might cause dryness and dyspareunia. So we have to preserve that particular segment. Other examples in here, you will see a microcatheter. You will see the vascularity of the fibroid. After embolization, preservation of the cervicovaginal branches. Another one from the left side, you will see highly vascular, and then the vascularity persists even after the venous phase. And then a finished product, and you will see that the horizontal segment of the uterine artery is preserved. So this is the schematic diagram for embolization. So we go selectively into the fibroid supply and then inject particles. So these are the particles suspended in contrast, so we can see them as they go into the fibroid blood supply. And the particles are measured exactly in micron. 300 micra, 500, 700, 900, or 1,000. How do we how do we determine the size? So you have to determine the size of the particular blood supply. The ovarian vessel is about less than 500 micra. So you should not use particles that should be within this size. The reason being is that you know very well there is a particular anastomosis between the ovarian blood vessels and the uterine blood vessels. So if you put particles into the fibroid, some of them will escape through the anastomosis and they will go into the ovary and will cause ovarian failure. Then the supply to the fibroid is about 500 micra. Then the intrauterine branches of the uterine artery is about 500 to 1,000 micra. And then the extrauterine branches of the uterine artery is 1,000 to 2,000. And then the vaginal branches is about 1,000 micra. So as a rule, the particles that we use should be within 500 to 900 micra. And you have to remember that the prearterial level is about 300 micra. You want to preserve the prearterial level because you don't want the uterus to infarct. So could still allow collaterals through the prearterial level, just in case the uterus has to recruit some blood vessels from the other branches of the internal ilia. So this is the vascular anastomosis. That's the uterine blood vessel. You will see that anastomose in the ovarian blood vessels. And then if you inject contrast, they could potentially go into the ovarian blood supply. And similarly, the vaginal branches and internal pudendum. So the blood supply is very dense. It's a well-developed peripheral. And for that reason, myomectomy, the blood loss is significant because there is a combination of dense peripheral blood supply as well as centripetal internal blood supply. And most of the time, specimen that has been studied is that there is bilateral supply to the uterine fibroid. Another case, you will see in here a microcatheter selectively selectively lodged into the fibroid supply, highly vascular. You will see the peripheral as well as the centripetal distribution of the internal vascularity. Another one on the right side, highly vascular. Look at the capillary phase, parenchymal phase, deeply stained with contrast, highly vascular tumor. What is the endpoint? So occlude all the branches to the fibroid, but make it a point to preserve the horizontal portion of the blood vessel, at the same time preserve the cervico-vaginal branches. This is the pre, it's the fibroid, and this is the post, the vascularized, but there is preservation of the horizontal segment. So let's go back to the case now. So we did an aortogram. This was supposed to be a scene, but it doesn't function. So we did a puncture on the groin, the right common femoral. Now we're doing the aortogram. And by doing the aortogram, we're outlining the uterine blood vessels. They're large, bilaterally, and very tortuous. Then later on, you will see the fibroid being supplied by the blood vessels. And then progressive fill-up of the fibroid. And then this is the staining produced in the large fibroid in the lower uterine segment. This is staining produced by the fibroid in the fundus of the uterus. And then we went into the left side, and then we went into the internal iliac and did injection, and to outline the origin and the point of takeoff of the left uterine artery. And then later on, you will see the catheter selectively going down now into the horizontal segment, injection, and you would see the dense vascularity within the fibroid. And this is the finished product. The fibroid vascularity is already obliterated, and you will see preservation of the horizontal segment as well as the cervical and vaginal branches. So through the same approach, we went into the right internal iliac, and then selectively and progressively went into the right uterine artery, and then injection of contrast outlined the fibroid. And this is the finished product. Fibroid is gone, meaning the vascularity. Horizontal segment is preserved. Cervico-vaginal branches are preserved, especially in this particular later phase of the cycle. And then post-embolization aortogram, no fibroid vascularity, but preserved distal segment of the blood vessel, the uterine blood vessel bilaterally, no fibroid staining, and for comparison, you will see this is the pre-embolization. You will see the deep staining of the fibroid compared to the obliteration of the fibroid after the embolization. What is the expected time course of recovery? Within 8 to 12 hours, there's severe pain. That's the reason why they're placed on PCA pump in combination with ketorolac. Then 3 to 5 days, the pain should diminish. Then 9 days, expected to return to work or normal activities. Then 4 to 6 weeks, there could be intermittent discharge. And 3 to 6 months, about temporary amenorrhea, about 1% of cases. And then 6 months onward, permanent amenorrhea in about 3.7% of cases. Complications, red degeneration in less than 5%. This is usually large fibroid. Infection, inadvertent embolization, you could produce sciatic nerve palsy, but the occurrence is less than 0.5%. Ovarian failure in 2 to 4%. Pelvic vein thrombosis and PE about 0.4%. So there should be some stockings to be used to prevent the occurrence of pulmonary embolism and thrombosis during the confinement. And then the concern for weakening of the wall of the uterus during pregnancy. And post-embolization syndrome, I think the occurrence of this is less than 10%. They present with fever, malaise, pain, and some uric acid because of the degradation product from the embolization. This is usually self-limited, and they usually respond with NSAID. Expected changes in volume. I don't want to bore you with this case series, but it's just to show you what is the expected change in uterine volume. It could range from 29% to 51%. But the range is wide, as shown in this particular study, ranging from 0, no effect at all, to 84%. How about technical success? So it depends on the series. It could range from as low as 84% to as high as 100%. In terms of outcome, menorrhagia improvement, bulk symptoms improvement, and fibroid volume reduction. You will see in here in this series of 5 studies, it ranges from 81% to 95%. Improvement on bulk symptoms, 93%, it progressively at 3 months, 64, and then progressively going higher to 92% at the end of 1 year. Again, the same observation, volume reduction usually cluster around 50%. Look at it, the same results, improvement, high 80s or low 90s, bulk symptom improvement ranging from 80 to 93%, similar to the previous cluster of case series. And again, you will see that fibroid volume reduction clusters around 50% volume reduction. Similar findings. And then this is the EMI trial. The EMI trial is from 28 Dutch Hospital. It's a randomized clinical trial consisting of 177 symptomatic fibroid randomized into fibroid embolization 88 and almost a similar number of hysterectomy about 89. When you look at the results, failure of fibroid is about 5%. Major complication is 4.9 in fibroid embolization, not significantly different from hysterectomy. When you look at minor complication, about 58%, the p-value is less than 0.05, so it's statistically significant. And again, you have to look at readmission. Readmission from fibroid is about 11%. But the advantage of this from this case, from this randomized clinical trial, the length of stay is usually 2.5 days. Most of the time, it's usually overnight. The EMI trial, technical failure was 5.3%, clinical failure was 17.3%, and then difficult anatomy is a problem, 4%, and failure to do catheterization of the other side is about more than 10%. And they found out that technical failures usually increase with a single fibroid, especially if the uterine volume is small. Why? The vascularity might be very small, too small for the catheter to go selectively. And in this EMI trial, overall complication rate is very high, 28% during the hospital stay and about 60% during the 6-week stay. This is a combination of major and minor complications. And the observation from this trial is that amount of embolization material is associated with the complications. So for that reason, if you have a uterus that's sized more than 24 weeks, you will be using a lot of contrast medium you'll be using a lot of particles, and for that reason, you would expect more fever, you would expect more major complications, and they would expect more high pain score. How about the UK trial? It's called the REST trial. It's a small trial, about 106 fibroid embolization, only 51 surgical group. Length of hospital stay 1 day for fibroid embolization, first surgery 5 days. Symptom-free at 1 year is better with surgery. You look at the follow-up, it's just a 1 year follow-up. 12% major complication with the fibroid embolization, and 9% required a repeat procedure, and 13% required readmission during the 4 to 6 weeks or 1 year follow-up period. This, again, a very important evidence-based. When you look at the registry, it is the highest, meaning in terms of population, it started with 2,112. And then progressively dropped to 85% at 6 months, then progressively dropped to 1 year at 80.5%. When you look at the results, quality of life score improvement in majority of the cases. No improvement in 5%, and then about hysterectomy requirement in 3%, and then about 4% required additional gynecologic intervention. And then between 6 to 12 months, about 6% required another intervention. Amenorrhea in about 7.3%. And you have to take note that those that go into ovarian failure, a lot of them, 86% of them are already 45 years and older. And then satisfaction is about 82%. And then this fibroid registry has been extended to 3 years follow-up. 90% remain, and then about 60% only completed the survey. When you look at mean symptom score improvement, they were able to maintain it up to 3 years of follow-up, about 41.4 reduction in the point improvement. And then similarly, quality of life improvement about 41 points, and then they were able to carry it out. Baseline, were able to carry it out up to three years of follow-up period. Then the Kaplan-Meier curve, up to 3 years, hysterectomy was needed in 10%, myomectomy in 3%, and repeat fibroid embolization in 2%. Long-term follow-up, because this is the problem. Initial problem was there was no long-term follow-up. There are 2 long-term follow-up. This is a prospective observational study of 5 to 7 year follow-up. You will see in here that about 75% return to normal. 78 or 80% resolution of the symptoms, but again, high requirement for further treatment, about 16%. Another long-term study, 5 year follow-up, same results. You will see that satisfaction is about 72% in terms of symptom control, but failure is about 20%, and then a high need for hysterectomy about 14%. This is now the highest of the evidence. This is the Cochrane collaboration. So this is based on 6 RCT of 732 women. There were 3 trials comparing embolization versus abdominal hysterectomy, 2 trials comparing fibroid embolization versus myomectomy, and 1 trial comparing fibroid with a combination of hysterectomies and myomectomies. So all were randomized clinical trial. And then participants, all symptomatic fibroid, a combination of symptoms. It could be menorrhagia, metrorrhagia, pain, and bulk-related symptoms. And then the treatment is hysterectomy, myomectomy, or pure uterine fibroid embolization. The clinical outcomes, the principal ones, are satisfaction within 12 to 24 months and 5 years, and ability to carry on live birth, comparing fibroid embolization versus myomectomy. These are the secondary outcomes. We will not go over them. We will look at them in the results. So what favors surgery based on the meta-analysis, we don't have time to look at the forest plot. All of these clinical outcomes favor surgery. Live birth, further intervention within 2 years, meaning less intervention within 2 years, less minor complications within 1 year, less further need for intervention within 2 years and within 5 years, and less unscheduled readmission within 4 to 6 weeks follow-up, and the FSH, meaning ovarian failure during the first 6 months, is less compared to fibroid embolization. Then ability to conceive is more, and favoring surgery. How about fibroid embolization? Based on the meta-analysis, based on the forest plot, all of these are favored by fibroid embolization, the need for blood transfusion, major post-procedural complications within 1 year, duration of the procedure, the length of hospital stay, and resumption to normal activity. The following outcomes did not show any significant difference. Satisfaction within 12 to 24 months, satisfaction within 5 years, adverse intraprocedural complications, no significant difference, any complication within the first month, later minor complications, major post-procedural complications, FSH levels above 40, within 2 years, there's no significant difference. Fibroid recurrence in comparison with myomectomy within 2 years, there's no significant difference. And health-related quality of life, including sexual life, within 1 year, there's no significant difference. So I would just like dwell on this forest plot a little bit, because this is very important in decision making and patient selection, the need for further intervention in 2 years. You would see in here, based on the forest plot, that all of the trials, you will see that they favor surgical procedure. One trial, they cross the line of no effect. One trial here, so at least 2 of the trials, they're crossing the confidence interval is crossing the line of no effect. But when you look at the pooled result, it's a very small diamond, meaning the 95 confidence interval is very short, and therefore it's a significant difference between the 2 groups. And we look at the data, meaning the need for further intervention within 2 years, 16% in the embolization group versus only 5.5% in the surgical group. And similarly, when you look at 5 years, the need for further intervention within 5 years, all of the trials would show favoring surgery, and the pooled result, a small diamond, the confidence interval, 95% confidence interval is very narrow, it's a very significant finding. It doesn't cross the line of no effect. And when we look at the raw data, 30.4% in the embolization group versus only 7.6% in the surgical group. So this is one of the major considerations when you're considering offering a patient for fibroid embolization, the high need for intervention within 2 to 5 years compared with the surgical counterpart. Other meta-analysis that are included here, you would say that hospital stay, recovery time would favor fibroid embolization, and even major complication in this particular meta-analysis, including 1, 2, 3, 4, 5. 2 of the trials that we reviewed, the EMI trial and the REST trial, are included in here. You would see in here that although most of the trials, the confidence interval crosses the line of no effect, the diamond, which is the pooled result, it's off the line of no effect, so meaning it favors uterine fibroid embolization. And then the other meta-analysis, you would see that need for blood transfusion, length of hospital stay, both favor fibroid embolization. And then pain during the first 24 hours favors fibroid embolization. But again, this systematic review showed a different finding as far as major complications is concerned, early post-procedure complications. The diamond is very wide, so the confidence interval is very, very wide. And at the same time, see how the diamond crosses the line of no effect. So there's no significant difference between the 2 treatment groups. Guidelines. So this was the OB/GYN guidelines in 2005. At the time, they recommended the fibroid embolization, but with caution. It should be somebody with symptomatic, not only for aesthetic reason, because some women might come to you because of the protuberant abdomen. They presume that with private embolization, the waistline should regress, but initial data doesn't show significant regression of the waistline if you do fibroid embolization in somebody who doesn't have symptoms. And then the warning in here is that you should only offer fibroid embolization if the patient is willing to undergo hysterectomy once there is failure of the procedure or there is a major complication of the procedure requiring hysterectomy. And then the OB/GYN group, American College of Obstetrics and Gynecologists, and again, a publication in 2008. These are alternatives to hysterectomy in the management of fibroid. They changed now, they became more open now to the use of fibroid embolization. The one highlighted in red Based on long-term and short-term outcomes, UAE is already a safe and effective option appropriate for selected women who wish to retain their uterus. So this is the problem. A lot of research is still needed in patient selection. Which of these women really benefit from fibroid embolization in favor of a surgical procedure? The other guideline, we have the UK counterpart. So when I use, this is my personal practice. I look at both sides of the world, American guideline and UK guideline. So this is the NICE, National Institute for Health and Clinical Excellence, a recent one, 2010. It's also concordant with the recommendation of the Society of Obstetrics and Gynecology in the US. They favor, they recommend, and there are no major safety concerns. But there is a warning that there should be normal arrangement in place for clinical governance and audit. Conclusions. So based on what we have reviewed as the evidence base, and the strongest evidence is from the CONCURRENT collaboration systematic review of 6 trials, we can come up with this conclusion without, I guess, without bias. Fibroid embolization appears to have an overall patient satisfaction similar to hysterectomy and myomectomy. It offers advantage with regards to shorter hospital stay and quicker return to routine activities. But the problem is, it is associated with higher likelihood of minor complications, increased likelihood of requiring surgical intervention within 2 to 5 years of the initial procedure. And then there is a low-level evidence suggesting that myomectomy may be associated with better fertility outcomes than fibroid embolization. I show you the forest plot and the ability to carry on pregnancy to term. There is a significant difference between the two. Thank you.
How common is ovarian failure after a UAE?
This is because of the ovarian anastomosis, some of the particles might go into the anastomosis and then probably diminish the blood supply of the ovary temporarily. Permanent amenorrhea, I guess about 2 to 4% only.
2 to 4.
Yes. But one serious claim about 7%.
And then, how long does the procedure actually take when you?
It depends. Most of the cases I do in here, these are morbidly obese, so technical difficulty is a problem. Not only that, I struggle with the groin. After you struggle with the groin, and then you struggle with visibility with fluoro. Remember the density that has to be penetrated by the X-rays. Recently, visualization and technical difficulty is the problem. But overall, it should be about the exposure to. If you look at fluoroscopic time as your threshold, meaning as your baseline, excluding the pre and the post procedure, fluoroscopic time would range about 19 minutes to a high of 45 or 48. But that, of course, excluding the pre and the post.
Are there any physical limitations that your table cannot handle?
Right now, we have purchased a new table. It used to be a problem in the past because the load limit is 350 pounds. And now we acquired a new one. I think the load limit is up to 620 pounds.
We got a couple more patients this week.
Yeah. Seriously?
Yes.
How are you handling your patients that have complications? I'm in private practice, and sometimes there's not a lot of communications between physicians. And if a patient has gone to have an embolization and develop fever and infection, are they calling you or are they calling them?
Yeah, they usually call us. And then routinely, I schedule a 1-week follow-up. Then based on the assessment, I could schedule 2 weeks, 3 weeks, or 1 month, 2 months, depending on the initial follow-up.
So if they had to be admitted to the hospital?
Depending if you're suspecting an infarct that might need emergency surgical intervention or infection. But usually, I think the limited series that we have, unfortunately, my logbook has been lost. I have not found it. But fortunately, with our group, even with the morbid obesity, I can remember only one major complication. There's somebody with a sleep apnea, with morbid obesity, I think about 400 pounds, and then some cardiac problem. And then after the procedure, he was admitted in 2G, and then they did not monitor the O2 sat, and that's it, the saturation overnight that led into acute coronary syndrome. But luckily, it was a non-complicated acute coronary syndrome.
What do you do for thrombosis prophylaxis? For DDG.
Prevention.
What do you do for that?
You can we can put stockings, and then if there's no concern for bleeding, then we have to use a prophylactic dose of non-molecular weight heparin.
You do a prophylactic dose of Lovenox?
Yes. After we are sure that we have secured hemostasis in the puncture site. Post-procedure.
You have a patient who needs anticoagulation because of a history of a clotting disorder or something. Are they still candidates for UAE?
Yeah, as long as you bridge the Coumadin to a low molecular heparin, just withhold the low molecular heparin the morning of the procedure. And then you can resume it a few hours after.
So when they're admitted initially, like to be on the PCA for the first 24 hours, are they admitted to gynecology or to interventional pump service?
Under our service. Our privileges is only limited to overnight. Then if they stay more than 2 nights, then we have to transfer to the referring service.
What are they typically readmitted for? You said there's a readmission rate. What are they usually coming back from? Is it fever, infection?
Fever, infection, that's the usual concern that we're afraid of. Because although fatal sepsis that has been reported on isolated cases, there are only 2 reported cases. But I don't know if there's a publication bias, because you don't want to report your bad complications. So most likely there's a publication bias on death due to sepsis.
When they come back for readmission with fever, I mean, I would assume it's probably necrosis, tissue necrosis. Do you put them on antibiotics?
Yes. I do routine prophylactic antibiotics just 1 hour before, just a gram of Ansef.
So, outside the university, how prevalent is this out in the private world? Because the thing we run into here is we do a hysterectomy or send them to y'all in a not 400-pound patient and a regular patient. And there's a reimbursement issue, and there's all those things. And so, how prevalent is that out in the community or outside of here? Is it?
I'm not aware.
Not sure.
It's not very common. Actually, we probably, I think, maybe 2 or 3 a year.
Are they obese patients? Or people with multiple morbidities? Or are they normal
Obese
patients?
And,
I have ordered one. I have a patient who we've done a series of 3 embolizations on, who is not an obese patient, but she's a Jehovah's Witness with like a 30-week uterus, and absolutely refuses a blood transfusion and had urinary retention because of pressure on her bladder. So she got a series of 3 UAEs, and actually her symptoms have resolved. Her uterus didn't get much smaller, but her symptoms did resolve, and we've never done a hysterectomy on her. And that's one of the only situations that I've used it in.
Does anybody out of town do these, or are they all referred into LSU?
No.
yes,
She was getting
Really?
So there's somebody else.
But usually, we'll get a patient that comes in who says, well, I don't want a hysterectomy. They've heard about this procedure. So we'll refer them to him for a consultation, see if that person is a candidate. And then we try to communicate so that post-procedure if something happens. Because I got a call from someone who I didn't know had the procedure, and I was on call that night.
Right. They also do not have an admitting service, and so we have to admit them anyway.
That's what used to happen.
Yeah, here.
Before, I guess you were here, whenever I was a resident, they would just show up on our service sometimes. When we were running the GYN service, so that's good.
We just had that last week. We had a patient that came in and she had drainage, and we admitted her so that they could do a procedure. And then we kept open.
It's not this situation.
Have y'all had the occasion to do the emergency embolization with someone in Cambridge?
Yes, I think about 2 cases. Yeah, about 2 cases. There's one case, somebody who's pregnant, almost term, and then there's a large fibroid. So what we did was a two-stage procedure. We put a balloon catheter in the internal iliac bilaterally before the C-section, and then we inflated it to diminish the blood loss. And then probably after several months, the patient came back for fibroid embolization after the delivery.
How many are you guys doing here at LSU?
It's not that high. Our figures are not that high. I would say that I joined LSU in 2005, and then probably during my 9 years, I would say it's not over 30, but I'm not sure. I lost my logbook.
Does anybody else have any questions?